hand to Mr. David Limbrick MLC.
Thank you, Chair, and thank you, Premier, for appearing today. I'd like to start with a big question that lots of people have been asking me and I don't know the answer to. With regards to the government's response to the pandemic, the government's spoken a lot about saving lives, which is effectively, the disease causes a reduction in certain cohorts' lifespan, and therefore the actions are try and prevent that. However, the government actions themselves can also cause a decrease in lifespan. I'd put it to you that, things like poverty, things like mental and physical health issues caused by the government actions, things like suicide and all of these other things that cause decreases in people's life expectancy. Therefore, the claim that the government is saving lives can only be proven to be true if the actions of the government aren't causing more damage to people's life expectancy. What evidence or modelling is the government using to look at these harms that are caused by the government actions and therefore have confidence that you are in fact saving lives overall by the actions that the government's taking?
Thanks for your question. I understand the point that you're making, and none of the choices that we are presented with, none of the options that we might consider are without significant cost. There is no perfect answer to this. But the judgment was made not simply by our government and our public health officials, but national cabinet, so all First Ministers and the National Public Health Team, as it was at the time. And this is essentially a continuation of important strategic decisions that were made some time ago. So at the time it was Brendan Murphy as the Chief Medical Officer, now it's Paul Kelly as the Acting Chief Medical Officer, that if we had a situation where, back to my presentation, that graph with many tens of thousands of infections, so some countries have gone down that path and have gone for a herd immunity approach. That hasn't lasted very long because they've worked out that the only thing that actually delivers is tragedy. Now, I would just make the point, you mentioned some cohorts. The key point here, though, and the most worrying point, is that we see international data, and indeed we see data here in Victoria, people who are otherwise healthy becoming gravely ill and some passing away because of this virus. People of all age groups are becoming gravely ill and passing away from this virus. That's probably more from an international point of view than it is from our perspective, but that speaks directly to what occurs when you get volume, when you have mass transmission and you have not hundreds of cases a day, but many thousands, then you will finish up with a fatality rate that is exponentially higher than the terrible tragedy that we're dealing with now. It's by no means to say that it is not tragic, the number of people who have died. And I take your point that any intervention of this scale will see a number of other people in very difficult circumstances, and some of those will in turn be tragic. I suppose the issue becomes one of what option do you have? What choice do you have? Is there an alternative that our experts are advocating? Is there an alternative that the best science tells you will work to avoid both the fatalities that are directly attributable to the virus and, as you say, those fatalities or that hardship that is indirectly attributable to the settings we put in place to fight that virus? I suppose I'd make this point to you. One thing, it's very difficult to measure things that don't happen. It's very difficult to measure causation and leakages. But one thing I think we could definitely agree on, if our hospital system becomes completely overwhelmed, then it's not just COVID-19 patients who will wait for a machine to breathe. It's the hundreds each day of Victorians who need time-critical care because of heart attack, stroke, motor vehicle accidents, industrial accidents. Our hospitals, the acute time-critical care, the trauma part of our hospitals, are very busy places, COVID or no COVID. So I suppose that's something we've also got to factor in as well, that there's great hardship and burden. Do we have an alternative choice? And if we allow this to run completely wild, there's also a big cost, I think, in all of those that we'll not be able to care for, that we can really quite accurately predict. We've got years and years of data, and I'm happy to come back with some further details on that. But the number of people who can't wait, they are absolutely the sickest patients. And if all the ICU beds, even if you've doubled, tripled, quadrupled them, if they're all full, then those people finish up waiting. And if you wait, you die. So that's part of the challenge also.
Thank you, Premier. I'd just make the point that there's this characterisation that there's either a hard lockdown or let the disease run wild. There's sort of a spectrum of responses that could happen, of course. That sort of brings me to a good point, though. What's the government's end game with this here, like the strategic end game? When the response was first announced by the government, the end game was fairly well understood, I thought, that we wanted to flatten the curve so that we wouldn't overwhelm the health system capacity, as you state, and the government needed to buy some time to increase the number of ICU beds and staffing and machinery and all that sort of thing. And that increase has happened. It's my understanding that, we haven't approached anywhere near full system capacity. And yet at the moment, we're in the hardest lockdown and hardest restrictions on individual freedoms that, Victoria's pretty much ever seen. And I don't really understand, and I think a lot of people don't really understand, what's the end game? Where do we go from here? And why are these hard lockdowns required right now, despite not actually utilising that capacity that we built up when the response was first announced?
Part of the challenge here is to try and get an accurate picture of what you've avoided, what you've not had happen, if that makes sense. So what we know, the first wave was about buying time, assuming that we couldn't flatten the curve. Not that we would ever think it desirable to stop flattening the curve. And there is a very important difference there. This is so wildly infectious that it gets away from you very, very quickly. And the 2-week time lag, or at least a week, and for safety's sake, you'd say a 2-week time lag between what a particular problem or a particular intervention does to the rate of infection. That's the other thing. So it's silent, it's rapid, and it takes some time before you notice the problem. It takes some time before there's a clear line of sight about how many people you've got infected. If you've got an R0 at 2, then you are doubling over every sequence period. That if you've got it at 3, you're tripling, and again, it's that absolutely exponential growth. So I suppose part of the problem is to keep it settled, you've got to go harder. You've got to assume the problem is worse than it probably is in order to avoid it becoming true, and indeed worse than that still. So I just say the first wave was not about flattening the curve so that we could then stop flattening the curve. All of our settings were based on buying time for the quite likely outcome that we wouldn't be able to flatten the curve. That's the New York, Spain, well, it's the whole of America basically, but Spain, Italy, France, the UK, the list goes on and on, where we've seen many tens of thousands of deaths. So it was an abundance of caution approach, but we were able to achieve the objective. As to the real part of your question though, so what's the end point now? The end point is to get case numbers down to as low a number as possible so that we can have confidence that we can manage those cases and the inevitable outbreaks that will occur and the inevitable transmission that we will see. But again, if you opened up now, just flip that graph around that I had in the slides. Without stage 3, without stage 4, there's no flattening of the curve. There's no moderate outcome. It takes off like a bushfire and you've got no chance of putting it out. And I suppose there is a delicate balance, Mr. Limbrick, about having created capacity. You could well argue, and perhaps you have kind of asked me in your question, well, why aren't you using that additional hospital capacity and therefore have some easier rules, some less tough rules? The problem is, though, for every 100 patients that we admit into ICU, there is a percentage that will not come out. And it is far better for them not to get this virus than to get it and get the best of care, even in a system that bought time and grew its overall size. That's the binary nature of this. And again, I wouldn't want anyone watching these proceedings or reading the transcript later to think that this is something for the frail-aged only. Yes, it is significant. It's a very significant challenge for those who are already unwell, those who are frail in age. But we're seeing growing evidence of people who are otherwise healthy that are dying, and we're seeing growing evidence of people who are otherwise healthy and they don't get over this like a common cold. They have it as a chronic condition for a long time. And that's the key function of novel viruses. We don't know everything about this, so you've got to assume the worst. Does that give you a sense of?
Yeah, but with the idea of, slowing the virus down by flattening the curve, I get that, but it's sort of a lot of the language that you're using and that the government is using, and that these ads that have come out, that seem to be trying to scare the wits out of people about the virus, is that we can somehow stop it. And the suppression strategy, my understanding is it's not meant to stop it, it's meant to slow it down so that we can manage it and not have our health system overwhelmed. But some of the language seems to be that the government is aiming to get rid of the virus and that no one's going to get it at some point. But I don't see how our strategy will actually achieve that. A suppression strategy doesn't get rid of the virus. It just slows it down so that we can manage it better. I
think we're in fundamental agreement. We're not pursuing a strategy where we eliminate this virus. That's not the National Cabinet decision. We are about suppressing it. And I suppose where the point of debate comes in and the proportionality of the response to the problem, any sense of uncertainty there or any debate about those points, they're essentially, Mr. Limbrick, a commentary on how rapidly this gets away from you. And at 400 cases a day, if you opened up, even quite modest changes, you would not have 400 cases a day for very, very long. Because what that R0 tells you, if it's at 1 or just under, which is where we believe it is now, that's every infected person is infecting one other person. So this is part of our great challenge. Finding the level that you can contain it at, and it's certainly not 400 or 500 cases a day. It's got to be much, much lower than that. And then the short-term pain of these stage 4 weeks, that's better than stage 3 for 6 months.
Thank you, Premier. I'm sorry to interrupt you there.